If not, then we go on in the program. And it's a pleasure for me to announce now my girlfriend, Iris Grunwald.
Thank you very much. Thank you, Klaus. And I'm so pleased because I also see in the audience my esteemed colleague, Dr. Bocardi, one of the most experienced neurointerventionalists. And I'm going to include you in the presentation and ask what you would do in a couple of cases. So may I just ask, how many of you in the audience are doing interventions in stroke or in the carotid? How many of you are dealing with carotid stenting or with thrombectomy procedures? So we're going to focus here now on what complications we have. What I always love about this conference is because there are so many ways where we can learn from each other, and I'm sure that many of the skills we use in neuroradiology will be translatable into the periphery, into other vessels. Okay, so understanding the procedural risk is really important when you're doing a risk assessment on whether or not to go for the treatment of stroke, especially now that the evidence has come out to also treat patients with smaller and more peripheral vessels. So the reported complication rates are between 5 and 15%, depending on the case and also depending on how peripheral you are actually going. Now, the main complications we have to deal with is vessel perforation. That's the most feared one. Then, of course, we have dissection. We have embolization to a new territory. It's called ENT, and also embolization in the same territory. Vasospasm, hemorrhage, either subarachnoid or intracranial hemorrhage, device failure, contrast-induced nephropathy, anesthesia-related complications, and usually forgotten communication errors. So let's have a look at the most feared one, which is perforation. So previously, remember the first big study, the Penumbra pivotal trial, complication rate happened only in 0.5%. Each time it was a misuse of the device. Nowadays, again, we're going more peripherally, and it's usually during guide wire or microcatheter advancement or during the advancement of the stent retriever. The risk factors are a tortuous vasculature, then, of course, excessive force on the catheter, and stiff guide wires, calcified, thrombi, and the more distal vessels. So what to do about prevention? So my number one rule is magnification, magnification, magnification. You not want to know where you're going. And for those who are not neuroradiologists, you may not use roadmaps so much. Use it. Use a roadmap, and you have a better, because you're used to working on a beating heart and moving images, it really shows you where the small vessels are. And another thing, and I'm not sure if you do the same, I very often use the tip of the wire and fold it around so it becomes a J, because then it is much less likely to go into a small perforator and to perforate the vessel. So you actually want this J shape. Don't do off-label use of devices. I know there's a big price difference, but so my favorite wire here is the synchro wire. Very, very soft, so the chances of perforating are low. I would not use peripheral stiffer wire for the intracranial anatomy. The wire should always lead the way. And another thing is, do not lose track of the wire. You always need to have the wire in the image. And another thing, stent retriever, do not push out the stent retriever when you've reached the area. Unsheath the stent retriever. Very often you'll see people who will push the stent retriever out, much more likely to cause a rupture there. You want to unsheath it. So the other thing is, especially if you have the patient in general anesthesia, always keep the sound on so you can hear the pulse rate of the patient. Question to you, what would be the first sign if you have a perforation? What's the first sign that will acoustically be heard? What will happen with the patient and with the physiological parameters? Anything going to happen to the pulse rate? It'll go up. Yeah, so suddenly you hear beep, 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 going much faster. Anything else you hear? Then you will look at the blood pressure. Is the blood pressure going to go down or up? It's painful. Subarachnoid hemorrhage is painful. You know that from patients who've had an aneurysm rupture. Pain as never before. So you'll see a raise in blood pressure in those patients. If you have a sudden increase in pulse rate, and if you have a raise in blood pressure, there is usually some pain, and what you do is you stop what you're doing, you check if there is any perforation anywhere. And now the next thing is, do not pull back the catheter. That's sort of the natural instinct. We think, oh, damn, we perforated, pull it back. This catheter, even if it's the microcatheter, even if it's the wire, may be the only thing that is still blocking the perforation. It buys you time to keep it inside. So withstand the natural instinct of, oh no, what did I do? And pull it back, keep it in there, because it may be actually closing the perforated hole. Next thing is lower the blood pressure. Very interestingly, very often you hear in thrombectomy procedures as well, probably taken from the aneurysm coiling, where we use a lot of heparin or anticoagulants to reverse the heparin, protamine use. In thrombectomy procedures, we hardly have any heparin. We do these procedures with probably only heparin in the flushes. We avoid giving heparin in thrombectomy procedures. So again, there isn't a lot to reverse. Probably legally you still should do it, but that should not be the first priority. The first priority should be to lower the blood pressure. That buys you time. And if you're working with a balloon guide, inflate it. Bringing a balloon up into the middle cerebral artery usually takes much more time. So then putting a coil up there, that will be the next things to do. So if there is now bleeding, the good thing is usually it stops on its own. The next injection you've done, lower the blood pressure, bleeding has stopped. If you need to coil, so we already say we have a universal code for it if something has gone wrong. Oh, damn, we know something is wrong. Okay, that brings out the emergency box. Already it works, sometimes working already with a 2-tip catheter. For example, the Prowler, for which you can bring a stent retriever, already has 2 tips. You know where to release a coil. But if you have to coil, do we want to release the coil immediately? So I usually don't release the coil. I put the coil out, but I do not detach the coil. I wait. My time usually for waiting is about 8 minutes. I don't know what you do. Yeah, same, about 8 minutes. Give it some time. Pull the clot back and see if the bleeding has stopped. You may have avoided closing off permanently a vessel. And I would do that 2-3 times, see if there's any change. And if there's no change, then you can see if you glue the vessel and you sacrifice the vessel, onyx, glue, and put it in. After that, you do an image, I call it DynaCT, the Siemens term flat panel CT, to see do we need a drainage, do we need decompressive surgery. Okay, vessel perforation. So good news is it's a relatively seldom complication. If it happens, it often happens in the peripheral vessels, where there you can occlude them, or bleeding often stops on its own. Dissection, the next one. What is the first sign of a dissection? Always have a good image beforehand. And if you suddenly see a new stenosis forming, that is a sign that you could have caused a dissection. So new stenosis, big warning sign. Intimal flap can be seen as a double lumen or as a contrast pocket. Risk factors are if the patient is a smoker. Repeated catheter exchanges, excessive force, excessive traction. What you can do to prevent it, use soft catheters with distal access catheter. No large gap between the catheters. Use a catheter in between, so not the big sheath and push that up and then only a wire inside. Smaller, smaller, smaller. Telescope technique, as you were showing earlier on. Slow movements so that you can still react if you feel resistance. And again, magnification, magnification, magnification. I see people working on those tiny images, whole brain visible. You don't know where you are. You don't know where the small vessels are. Magnify, minimize wire exchanges. And if something happens, what do? So this is a stroke patient. We've got an occlusion of the vessel. Do we immediately, in this case, what you're seeing here, this is where I would have gone for stenting. But you need to know that if you stent, you need to give dual antiplatelets. Again, this increases the bleeding risk of the patient, and the natural prognosis of a dissection is very good. So the first attempt could be a wait-and-see approach. Now, next thing, embolization into a new territory, or actually distal embolization. You've managed to get the first part of the clot out, and the second part has gone further distally into the vessel. And then you have in the posterior circulation, where you don't have the chance of using a balloon guide, actually it's been reported in up to 30% that you have distal emboli. Good news is, very often those distal emboli, once you have restored most of the flow, they resolve on their own. So again, wait and see, wait 5 minutes, do another run and see if it has dissolved. If not, you can consider following it. Yeah? Another big thing is the flushes. And that is something which is very different in neuroradiology to radiology, cardiology procedures, because I bet that many of you do not work with flushes, with those pressure bags, for every single catheter. That is one of the main differences in neuroradiology, and also with those tiny catheters, we see that it takes only 1 minute for those catheters to be blocked, and as you see here, there's then clot inside, and you unknowingly push the stent retriever through it, and suddenly you have got the whole 1 meter of 80 of thrombus pushed inside of the brain. So one way of avoiding it is having a flow body, yeah, or having someone positioned next to the drip lines to only watch the drips and see if one of the drips is not moving. So monitor the drip lines, or have a device that will alert you if it is not dripping. You can do additional thrombolysis, yeah, RTPA, for example, if needed. And you could also consider additional antiplatelet therapy, because to stop any additional adherence of thrombus on the already existing thrombus. And, okay, vasospasm, another thing, induced by mechanical irritation, mainly in the younger patients. Please do not give prophylactic medication to avoid vasospasm, as we'd often do in aneurysm treatment. The main reason, because what happens if we give verapamil or nibotipine, what happens with the blood pressure? Any idea? Come on, everyone knows that. Don't let me work on my own here. So if we give nimodipine, what happens with the blood pressure? Does it go up or down? Down. Is that good in a stroke patient? No. We're relying on the vascular circulation, we're relying on the perfusion and the rest of the perfusion. So please do not give that prophylactically. Usually, if you have vasospasm, it will resolve in a couple of minutes. Please avoid, for example, with the blood pressure, the tip of the catheter always going against, for example, the petrous aspect of the vessel. Yeah, either use an angled catheter or go a little bit below. Keep the tip of the sheath and of the catheter inside. If it happens, if you do need to give medication, counteract the lowering of the blood pressure. Subarachnoid hemorrhage. Subarachnoid hemorrhage does not necessarily mean the interventionist has perforated. Very often the assumption of the neurologists say, oh, we see subarachnoid hemorrhage, you must have perforated. No, actually that's not the case. Very often it is due to the stretching of perforators, especially in the Sylvian fissure and in the insula. It is reported much more with stent retrievers because probably you have more of the stretching, but it is not related to a worse outcome. So subarachnoid hemorrhage seen in 3 to 6%. So also another thing, avoid high pressure injections. So we do hand injections in the intracranial vasculature. So you would not, by any chance, do a pressure injection into a small vessel. Regarding intracranial hemorrhage, very often due to reperfusion injury, which is due to the breakdown, dead tissue, breakdown of the blood-brain barrier. And what can we do to avoid this? Blood pressure control again. Again, do a CT on the angio table right after you finish. Do a CT. And what we do is we aggressively lower the blood pressure. If we see, I'll call it white stuff, yeah, as you see here, on the CT that was acquired on the angio, we do not know, is this contrast or is this blood? This patient is at a much higher risk of bleeding, and we aggressively lower the blood pressure. and that is, of course, our alarm going off. So I'll talk about our communication tool later on, which apparently works around the world. So, but the other possibility that we have is we have the possibility of a photon counting detector. And not many of you would have seen a photon counting detector before. So there are only 2 at the moment in the world. This is the first mobile photon counting detector, and it is a new kind of CT that is able to differentiate different materials. We'll be presenting on that again tomorrow. Grant will be presenting on that. But basically what it can do is it can differentiate between blood and contrast. And the beauty is that it is mobile, so you see here in our setup, and you can immediately bring this small photon counting detector into the angio room. It minimizes metal artifacts. It is much less radiation than a normal CT, but it, for the first time, allows us the differentiation of different materials. So as in this case, where we do not know if it is blood or contrast, this is courtesy to Dr. Raj Gupta from Mass General Hospital, who has the other PCD scanner. Here, doing an ion overlay, we can say, this is contrast, this is not blood. It's a game changer that we now have in our neurocritical care management. The device-related complications, stent reaver, tearing off of stent reaver, biggest tip is don't unsheath the tip, the detachment, the area where it is attached to the pusher wire. That is the weakest point. Take the microcatheter over the over the detachment zone to avoid the stress, the shear stress when you're retrieving it. And another big problem is if we've placed a carotid stent in patients with intracranial stenosis and a carotid stenosis, and you have the stent reaver, you forget that you've placed the stent, and you're pulling it back, and suddenly you get entangled. So first rule is if you've placed a stent, try aspiration first, and otherwise have a buddy remind you, actually there's a carotid stent in here, and do not get that stent reaver entangled into the carotid stent. Nephropathy, I don't see it as a big problem. If a patient, in our case, has impaired renal function, this is an absolute emergency. We schedule them for dialysis. What we do not do is we do not do perfusion imaging. May be seen as a big controversy, yeah? But we do not believe in perfusion imaging, not really so much for the contrast, but because perfusion imaging is not reliable in the first 6 hours. But so we do not do perfusion imaging. We save 80 mils of contrast, but I think the contrast should never be prohibiting for a thrombectomy. Anesthesia-related risks, please prevent a drop in blood pressure when the muscle relaxants are given. That is related to a worse outcome. And to finalize with communication errors, example, we had a patient sent to us from a different hospital with a tandem lesion, intracranial occlusion, carotid occlusion. I always ask, is the patient, so this is our standardized questionnaire, my question is the patient on dual antiplatelet therapy? Is the patient on any anticoagulants, on any antiplatelet drugs? So answer was no, patient is not on antiplatelet drugs. So what do we need to do in that case? We need to give IV aspirin. We need to put the patient on antiplatelet drugs for placing the stent in an emergency situation. Now, unfortunately, the patient was, and later on the next day I heard about it, and they said, oh, but Iris, we sent you an email correcting that. I don't have time to see emails when I'm in the cath lab. So this is where we have a dedicated communication tool, and that communication tool gives us the possibility of standardizing the information that needs to be in there, and if there were any changes that come up in between, we would even see them come up on the screen in our angio room. It was also quite practical during COVID, but if there's any other information, we had another case where there was an additional subclavian stenosis of the patient, so the blood pressure measurement we were getting from one arm were not correct. So communication tool, very helpful to avoid communication errors. And with that, I stop. Thank you very much. If you have any questions, please ask them.
Are there questions?
What kind of antiplatelet drug you use? Your favorite, if there's a such term What kind of antiplatelet drug you use?
So we are lucky because we have IV aspirin available. And the difference is IV aspirin works within 10 minutes, whereas an aspirin tablet can take days to work, and an aspirin suppository of 300 milligram takes 3 to 5 hours. Clopidogrel, if you crush it up and give it through an NG tube, because most of the patients are not able to swallow, takes about 3 hours before it has any effect in the body. So our choice is aspirin, and if we do not have it, or if we need it, if we have complications, we are again lucky that our hospital has Cangrelor as the next choice. Cangrelor, quite expensive, but it works within 5 minutes. But very often these patients, especially if they have a large stroke volume, they may need decompressive surgery. And the Cangrelor can be reversed within 5 minutes as well. So the only thing to look there is because the half-life time is so short that you need to have the next Cangrelor vial available. You cannot then be, when the patient is on the ward, oh, where's the next one? And you have a couple of hours in between because the effectiveness is already gone.
Okay, thank you.
Thank you.